In this lecture, I am going to discuss the use of anti-diabetic medications in presence of chronic kidney disease in patients with diabetes mellitus. Chronic kidney disease is common in patients with diabetes and is associated with increased risk of morbidity and mortality. So when the renal excretory function is impaired, it presents challenges in prescribing for maintaining good glycemic control. So to understand the use of antidiabetic medications in chronic kidney disease, you need to have an idea about the glomerular filtration rate, which is an indicator of kidney disease. So a GFR 60 or higher is considered to be in the normal range, whereas below 60 may mean kidney disease and below 15 may indicate kidney failure. So starting off with the use of oral hypoglycemic drugs in diabetes patients with chronic kidney disease. Metformin is the first-line anti-diabetic agent for the treatment of type 2 diabetes mellitus. It improves insulin sensitivity and enhances glucose uptake by the peripheral tissues, decreasing the hepatic glucose output, thereby decreasing the blood glucose level. To be noted that metformin undergoes renal excretion. So when the renal clearance declines, this causes high serum concentration of the drug, leading to side effects. The common side effects of metformin are gastrointestinal side effects, but metformin associated lactic acidosis has been reported but appears to be extremely rare. But this side effect has been found to occur in patients with chronic kidney disease. So metformin must be stopped or discontinued at GFR less than 30 ml per minute, while dose adjustment is required when GFR is 30 to 45 ml per minute. The next drug is sulfonylurea. Sulfonylurea is considered to be an insulin secretagogue because it promotes the secretion of insulin by binding to the ATP sensitive potassium channels. The most common side effects of sulfonylurea are weight gain and hypoglycemia, but the risk of hypoglycemia is higher in presence of renal impairment. Hypoglycemic episodes may be severe in presence of kidney failure. Most sulfonylureas are excreted through the kidney and must be discontinued from the stage 3 of chronic kidney disease when the GFR is less than 60 ml per minute. An exception to this is glipizide, which is a sulfonylurea that is metabolized in the liver and is eliminated in bile. Therefore, glipizide is a sulfonylurea of choice in patients with chronic kidney disease. Now the next drug is pioglitazone. Now, pioglitazone is a PPR gamma receptor activator which is expressed in the skeletal muscle, adipose tissue and liver and improves insulin sensitivity, enhances uptake of glucose and fatty acids, increases fatty acid oxidation and increases lipogenesis. Thereby it improves insulin sensitivity in various peripheral tissues and organs. In terms of its elimination, pioglitazone is mainly eliminated in bile, therefore it can be used in patients with chronic kidney disease. However, there is increased risk of fractures in elderly patients, in postmenopausal women and in patients with chronic kidney disease. Therefore, prescribing is limited in these groups. Also, it has been shown that pioglitazone increases the reabsorption of sodium and water in the collecting duct and this leads to fluid retention. Therefore, it is contraindicated in a patient with congestive heart failure or with a past history of heart failure, and the use should be with caution in a patient with myocardial infarction because these patients are more likely to develop heart failure. So next we move on to the new anti-diabetic drug classes, that is DPP-4 inhibitors, GLP-1 agonists and SGLT2 inhibitors. The DPP-4 inhibitors reduce glucose through incretin mechanisms, namely the GLP-1 and GIP. So oral food ingestion stimulates the secretion of incretin hormones which promote insulin secretion, suppress glucagon production, slows down the gastric emptying and improves satiety. So through these mechanisms, the incretin hormones lower the blood glucose levels. These incretin hormones undergo lysis in presence of DPP-4 enzyme. So DPP-4 inhibitors, by inhibiting this enzyme, prolongs the action of incretin hormones and enhances the glucose lowering effect. So with respect to the pharmacokinetics of DPP-4 inhibitors, most DPP-4 inhibitors are renally eliminated. Therefore, dose adjustments are required at GFR less than 60 ml per minute. Now, to be noted that unlike most DPP-4 inhibitors that are eliminated through the kidney, linagliptin is eliminated through bile. Now, since it is eliminated through bile and is not dependent on kidney for excretion, it is safe for use in chronic kidney disease. Now, to be kept in mind that linagliptin can replace metformin as monotherapy in type 2 diabetes mellitus. Because in terms of efficacy, linagliptin is equal to that of metformin, and metformin is contraindicated or avoided in chronic kidney disease. Therefore, linagliptin can be used in place of metformin in chronic kidney disease. Now, when it comes to GLP-1 agonists, the new drugs such as linaglutide and dulaglutide have better renal outcomes compared to DPP-4 inhibitors. So they can be prescribed when the GFR is greater than 30 ml per minute. So GLP-1 agonists, particularly the new drugs that is liraglutide and dulaglutide, can be prescribed when the GFR is still higher, greater than 30 ml per minute, and they have better renal outcomes compared to DPP-4 inhibitors. Next, we come to SGLT2 inhibitor, which is a new antidiabetic drug class, and it appears to have some renoprotective action because of improved glycemic control. Secondly, it has blood pressure lowering effect, and thirdly, via direct effect on the nephrons, it acts on the sodium glucose cotransporter and inhibits the glucose absorption in the proximal tubule, causing loss of glucose in urine, thus decreasing the blood glucose level. A drug that belongs to this class is empagliflozin, which is demonstrated to decrease the glomerular inflammation, decreases the glomerular fibrosis, causes constriction of the afferent arteriole and decreasing the filtration in the glomerulus, and this is considered to be useful in kidney disease. So empagliflozin has superior renal outcome compared to GLP-1 agonists and DPP-4 inhibitors. Now let's speak about insulin. Insulin is considered to be the mainstay therapy in chronic kidney disease and diabetic patients. But the risk of hypoglycemia is profound in presence of significant chronic kidney disease. Therefore, dose adjustments are required with insulin therapy. So with dose adjustments and glucose monitoring, glycemic control can be achieved in the patient with chronic kidney disease. So to conclude, prescribing in a diabetic patient should include the following drugs. The first drug is SGLT2 inhibitors, and the drug is empagliflozin, which has renoprotective action. It has superior renal outcome compared to DPP-4 inhibitors and GLP-1 agonists. Secondly, the GLP-1 agonists and the drugs are liraglutide and dulaglutide can be used when the GFR is greater than 30 ml per minute. Amongst the DPP-4 inhibitors, linagliptin is the drug of choice because it is eliminated in bile, and it can even replace metformin because the efficacy is equal to that of metformin with less side effects. Pioglitazone can also be used in kidney disease because it is eliminated in bile, but it is associated with side effects. Amongst the sulfonylureas, glipizide is the sulfonylurea of choice because it is dependent on liver for elimination, and therefore it is the sulfonylurea of choice in patients with kidney disease. And lastly, insulin, which is considered to be as the mainstay therapy in patients with chronic kidney disease. Insulin can be administered with dose adjustments in diabetic patients with chronic kidney disease.